last reader block, and then you will be given 4 minutes of time, and the picture will automatically be changed, right? So in that 4 minutes, try to uh, mark all the questions. There will be one MCQ question and three or four SAQ type question. So in MCQ, you just have to tick the correct answer as you always do. And in SAQ, what you have to do is you have to write the correct answer. So you should copy that document which I have already sent of CPC, and then start writing with your computer, right, on that slot. And after completing these there are 6 cases. So after completing all the 6 cases, when it is done, then we will go again from the beginning. And as we are sitting here one individually, so one of the student can start with the cases. Uh, he or she should read the scenario and start answering the questions. And if suppose there is something goes wrong, then I'll come in and let you know what's the correct answer and how you have to solve it. So this is the way we did last time in renal block. So hopefully, inshallah, this time it will be also good. And suppose if you need little more time for any of the slide, you can open your mic and ask me to give little more time so that I can go back and increase the time. So basically, I have adjusted 4 minutes per slide. So after exactly 4 minutes, the time will change, the slide will change, and you will be having the other slide with you. So hopefully, inshallah, it will be a good exercise with you. Um, whatever questions you will be having, we will address not in this time, but when we restart, because this time is for you. As this slide will change with case number 1, you start uh, writing all the correct answers in your copied material document, and then after finishing that, we'll go back and we'll restart, and then one by one we will be discussing. So you will be giving me the correct answer, and if you have problem in any of the cases, you can ask direct question from me, and inshallah we'll try to solve it. So this will be the same pattern as you will be getting your exam, uh, and inshallah it will be good for you. So now we have 86 participants. So assalamu alaikum everybody. This is the last activity we are going to deliver today, and this is not a new thing. It's the same CPC as we did in renal block. So it's just a continuation of that. Inshallah, after completing this one, you will refresh your knowledge of your endo and repro. So I have kept 3 cases of endo and 3 cases of repro, so that we'll try to touch up upon different cases, and you will be able to go through. So inshallah, should we start now, or should we wait another 2-3 minutes? As I said, it is already set for 4 minutes per slide. Yes, anybody?
Yeah, excuse me, doctor.
Yes.
I got a question related to the thyroid cancer.
We'll do it after completing this CPC activity, right?
Okay, sure. Thank you.
Yeah. So you're free to ask questions what you have in your mind. So please kindly download your document from your Moodle in your laptop, and then start writing uh, the questions, and then we will be discussing it. So should I start now? Are you ready, all of them? Still we have 96 students. So I can wait even 2-3 minutes more. Okay, so we have crossed 100 now. So we have more than 100 students around us. So I think this is a correct time to start. So let's start now. As you know, again, for the newcomers, I'm telling you that the document is already loaded up in Moodle. Just open that one, download in your laptops, and then starting with the first case. And I'm showing you the first case as a picture here, and then correlate with your scenario which is given in the first case, and then answer. There are one MCQ and 3 or 4 SAQs. Start writing the correct answer, and after completing this one, we'll be discussing those cases again. So we'll start with the first case. This is the first case. For the newcomers who have just joined, please kindly open your Moodle. I have uploaded the document. Open that document, download in your laptop, and start writing. Reading the first case because it is a case scenario and the questions. Correlate that with the picture. This is case number 2. Case number 4. Case number 5. अच्छा present that अभी मेरी क्लास चल रही है वैसे जैसे खत्म होती है आई टॉक टू यू ये बताएं कि ये कंफर्म है ना कि इनकी एक दिन बढ़ा दिया एग्जाम अच्छा मैं क्लास में अनाउंस कर दूं या नहीं करूं अभी ना करूं कुछ भी नहीं करूं हाँ ठीक है ठीक है सही 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 मैं इसलिए पूछा था आपसे कि अगर चलो ठीक जैसे कंप्यूटर का मैं टॉक टू यू फिर वो एग्जाम सॉफ्टवेयर पे करता है case number 6 now and this is the last case. So the cases are finished now. Are you all done?
Yes, doctor.
Okay. So I want to start with the case number 1 again. And I want one student to come up, read the scenario, and try to solve the questions. So it's liberty that anybody else can jump in on their mic and give their diagnosis or whatever. So we'll go one by one. Inshallah, it will be a good activity. So who's going to start with case number 1? Anybody from the whole class? Come up, open the mic, and start reading the scenario. Case number 1. Yes. Nobody is interested? Boys, girls, I want somebody to come up. Don't,
I
yeah,
can start.
sure. Thank you. What's your name?
Salwa.
Salwa, please go ahead.
Okay. So, should I read the case?
Yes.
Okay. A 22-year-old pregnant woman has not experienced fetal movement by the 18th weeks.
Mm,
By 18th weeks gestation,
mm,
and subsequently develops vaginal bleeding followed by passage of grape-like structures.
mhm,
Ultrasonography shows a snowstorm of cystic spaces, but
mm,
no fetus, and the image is shown below.
mhm,
Shown. The
mhm,
uterine contents are evacuated.
mm,
Gross and microscopic images are shown.
mm.
What is the most likely diagnosis in this case?
Okay.
Um,
So, what's
the
your
option, the,
options?
the options are complete mole, incomplete mole, invasive mole, placenta trophoblastic tumor, and
Mm,
choriocarcinoma.
okay. What is your correct answer?
Complete mole,
Okay. So why are you calling it complete mole, Salwa?
because there's no fetus or any fetal content, and
Uh-huh.
it's all
Mhm.
cystic lesions, trophoblastic. Mhm.
Okay. By looking at okay, so because then we'll read the microscopic finding and then we'll discuss.
Mhm.
So anybody from the class has any objection of Silva's diagnosis, or everybody agrees that whatever she's saying is right? So everybody agrees, right? Okay, Silva, can you read the question, first question of SAQ?
Describe the gross findings.
Okay.
What I can see is that there are villi, there are edematous and cystic.
Mhm.
Um, uh, I don't know what else.
Okay.
Yeah.
Anybody in the class can help Silva, or can add their histological finding. Yes, these are chorionic villi. And you are saying, Silva, that they are
Edematous or cystic.
adenomatous, distended, right?
Yeah.
Okay. Normally, okay, let me on
Yeah.
my,
There's also, doctor, proliferation of the trophoblasts.
exactly. So just for your, that's just for example. Normally, if you see placenta, it looks like this one, right? Almost throughout the placenta, the size will be this much or slightly larger and lower than this one. But this one is quite edematous, right? Bigger in size. Can you see that, right? Number one, as the other student, what's your name? The male student. Hello. Yes, your answer was correct. There is not only edematous villi, but also there is proliferation of the cells here, right? Uh, any other thing which can you can see in this microscopic picture? Hmm? So what is the other thing which you can see here? Anybody else?
Edema of the stroma.
Edematous stroma. Yes. Any other thing?
No, that's what I can see, doctor.
Okay. So there is no blood vessel here, right? Do you see any blood vessel? No. So this is also one of the feature. You can see cistern. This is probably not that much easily be identified, but there is a cavity here. This one. This is called cistern, which you only see in complete mole. You hardly see in a partial mole. So there are 2 3 points. One, edematous big villi, number one. There is a proliferation of these trophoblastic cells, two. Number three, there will be no blood vessel. Number four, you can see a cistern formation like this one, cavity in between, right? And there will be no fetus because in a partial mole, you probably can see fetus, a small fetus. But here there'll be absolutely no fetus, right? So this is about the histology. Okay, Silva, can you read question number?
The third question, we answered the microscopic as well.
Yeah.
So, yeah.
Oh,
Why should serial HCG levels be obtained after dilation and curettage?
so
I think to make sure that we've removed all the trophoblastic tissue from the the uterine cavity.
mhm,
Also, as well, might be a risk of it converted to choriocarcinoma. So that
mhm.
as well. I don't know if there's any other
Yeah,
reason.
yeah. So normally what happens that as you take out the whole grape-like structure or herediform wall from the uterus, the HCG level should come zero, right? But if the HCG level is still high, means either you have left some of the pieces behind, or it is invisible, it has invaded to the uterus, or it is converting into choriocarcinoma, right? Okay, the last question.
After evacuation, her serum HCG remains elevated. What should you be concerned about? I think it's
Not
the same answers
yes.
as
So exactly. So usually, what happens? The third answer will be after the evacuation. What you see after DNC, it should be zero HCG level. But if the HCG level are increased, means either she might be having invasive mole or it has been changed into choriocarcinoma. Okay. So there is only 2.5% chance that complete mole can change into choriocarcinoma. Incomplete mole almost they does not show this activity changing into choriocarcinoma. So everybody is happy with this case. Any questions from this case, or should we move to the other one? If you see the gross structure, you can see these grape-like structure, right? So in a complete mole, the grape-like structure are a little bit more prominent, bigger in size. But in partial mole, you can see hardly smaller one, like this one, and no big grape-like structures are seen. But in complete mole, the grape-like structures are little increased in size. Even you can see in ultrasound, you can see this structure here, right? Okay. Are we done with case number one? Can we move to case number two? I want some other students to come and read case number two. Thank you very much, Silva, for your contribution. Yes, any other student, please come up. Go ahead. Ibrahim, you want to start? Nobody is interested? Fatima? This is your activity, it's not mine. Please come up.
Doctor
Yes, please. What is your name?
Rakan.
Sorry?
Rakan.
Okay, Bismillah.
A 38-year-old woman had the increasing in abdominal enlargement for the past 8 months. On physical examination, there is abdominal distension with a fluid wave. Pelvic ultrasound scan shows unilateral cystic ovarian mass, 8 centimeters on the right. Paracentesis yields a cloudy fluid containing samoma bodies and cuboidal cell in clusters. The mass is surgically removed. The gross and microscopic appearance of the ovary is shown. What is the most likely diagnosis?
Okay. Read the options first, all 5 options.
Okay, A, serous cystae adenocarcinoma,
Mhm,
B, dysgerminoma,
mhm,
C, endometrioid tumor,
mhm.
D, granulosa cell tumor, and E,
Mhm.
Sertoli leading cell tumor.
Okay. So what is your diagnosis?
Maybe C, endometrioid tumor.
Endometrioid tumor. Why you call this as endometrioid tumor?
Because of the samoma bodies.
Do you think samoma body is common in endometrioid tumor?
I think as a complication of hyperplasia, maybe, and a sporadic form of.
Okay. Everybody agrees what he's saying, or somebody has their own other differential or other diagnosis?
It's present in serous adenoma.
Serous adenocarcinoma, right? So
Yes.
why you are saying serous adenocarcinoma? What's your name?
Basil Jabbar, because
Okay.
of the samoma bodies.
Yes, because of samoma bodies, you say that it is serous adenocarcinoma. Anybody else who is, now we have 2 diagnoses. One is endometrioid tumor, and the other one is serous adenocarcinoma. Everybody agrees, or definitely there should be only one diagnosis. So who is supporting which one?
Serous.
Serous cyst. Okay. Anybody
Yes.
else? Anybody who says endometrioid?
Serous endometrial carcinoma.
Serous.
Sorry, serous endometrial.
Serous
Serous adenocarcinoma.
serous adenocarcinoma.
And why you are saying this?
Because of the presence of samoma body and proliferation of papillary.
Yes. Okay. Now let's start with the questions, and then I'll come back to it. So the correct answer is it's a serous adenocarcinoma, right? Because we have a proliferating papillaries here. You can see these papillaries, this papillary, right? These papillaries here. But you can also see papillary infiltrating into the stroma. This is a clear infiltration of the tumor cells into the stroma. So when you see this tumor into the stroma, then it is malignant. If you see just proliferation of papillary processes outside and the stroma is clear and the features of malignancy is there, you call it, what you call it?
Cystadenoma.
You call it borderline tumor, right?
Yes.
Serous borderline tumor. And if it is benign, no malignancy, malignant cell, you call it cyst adenoma, papillary cyst adenoma. Okay, because now not only you see the papillaries, so you call it serous cyst, papillary serous cyst adenocarcinoma, because You can see the papillary structures. These are lined by columnar epithelium, and some of the cells are infiltrating into the stroma. Now you call it frank malignant. So serous papillary serous cyst adenocarcinoma is the correct answer. Okay. And now the other diagnostic feature is a psammoma bodies. Remember, psammoma bodies you can only see in serous cyst adenocarcinoma, right? You cannot see in mucinous carcinoma, or you cannot see in any of the other ovarian tumor. So this is a diagnostic feature of serous cyst adenocarcinoma. Okay, let's read the SEQs. Question number 1. Yes.
How will you grade this lesion?
Okay, so how will you grade this lesion? What is your answer?
I don't know.
Anybody? Anybody from the class? No problem. How will you grade it? Okay, let me define this thing. Anybody else? Yes, come on, come on. Don't worry. This is just a learning session. If you say something wrong, I'm there to correct it. And by this, you will understand the things more clearly. So if
Degree of
anybody,
differentiation,
sorry,
degree maturation of the cells, high
Okay.
grade or low grade.
Yes. So there are two things, right? Either it is low grade or high grade. So what is your diagnosis? What do you think this is?
Low grade.
Low grade. Now, for having low grade tumor, you know, the size of the cells are too big, you see, and you can see extensive mitotic figures. You know, this is one mitosis, this is another mitosis, and this is another mitosis. There is large amount of pleomorphism and hyperchromasia in this one. So I will mark it as a high grade one, right? Because the morphology of the cell, if you go in a high power, you can see a lot of mitotic figures. These are all mitotic figures. So in low power, low grade, you cannot see this much of mitotic figures. So in my opinion, this is a high grade one. So one thing is clear. Now, before when we were students, there were 3 grading system: mild, moderate, and severe. But now, instead of 3, they have just converted to low grade and high grade. So this one is a high grade malignant lesion. Okay. Come to question number 2, SEQ. Describe the microscopic feature. Yes. Anybody? We have already discussed this thing, right? You just have to say, that's all. So microscopic feature, what is that?
Papilla, proliferation,
Papilla.
and the presence of psammoma body.
Yes, good, excellent. So we have papillary projections, we have infiltration of the cells in the stroma, we have psammoma bodies, we have lot of mitotic figures. We show this. Yes, go ahead.
And poorly differentiated cell with presence of mitotic figure.
Yes, good. So we have poorly differentiated cells like a lot of pleomorphism, hyperchromasia, lots of mitotic figures. So these are all microscopic features which you are looking at here, right?
Yes.
Coming to question number 3. Which gene mutation do you expect in this patient after grading the tumor? What do you expect? Yes?
B53 mutation.
Sorry?
B53.
Yes. Anything else? Excellent.
I'm not sure, but BRCA1.
BRCA1, BRCA2. Remember, P3 shows this tumor as a high grade, plus BRCA1, BRCA2, both. When you see BRCA1 and BRCA2, and plus 53, it goes towards high grade tumor.
Yeah.
If you don't see P53 and BRCA1, BRCA2 is not there, then it probably is a lower grade one. Okay, so you
Okay.
can expect that you might have all three mutation of the genes. Okay, come to question number 4. Yes, go ahead. What is the prognosis of this tumor? Yes, come up.
It is aggressive tumor, so I would think poor prognosis.
Poor prognosis. Excellent. So these are all the questions which I have asked, and exactly the same amount of or same thing will be asked in your SEQ type questions, right? So you had to see the questions, read it, and then come up with your answers, right? So it will be just like this. So the SEQ, you have to write something. We will try to have either a single liner answer or two-liner answer, not more. Or we will ask mention two findings, or mention 3 finding, 4 finding. So just you have to write just 4 things. 1, 2, 3, 4. For example, in this case, you can write that papillary processes, pleomorphism, hyperchromasia, somoma bodies. Suppose 4 things are asked. Just for indicate 4 of the things. 1, 2, 3, 4. You don't have to write the full sentence of this. So this is how we are going to give you the SEQs. Okay, coming to case number 3. Who is going to read question number the case number 3 from the class? Yes, go ahead. Yes, go ahead. Basil, Ibrahim. Yes. Nobody is interested? Majid? Abdullah? Yes. Go ahead. Read the case first. Anybody?
I can read it, Doctor.
Go ahead. What's your name?
Rahim.
Okay, go ahead.
A 29-year-old woman noted a right breast lump present for 5 months. On examination, she has a firm, irregular 7 centimeter mass, but no palpable axillary lymphadenopathy. After resection, the gross appearance of the breast lesion is shown. It's ER and PR positive, but no HER2 new amplification. What's the most likely diagnosis in this case?
So what is your diagnosis?
Invasive lobular carcinoma.
Invasive lobular carcinoma. Okay. Everybody agrees what he is saying? Or somebody has a different diagnosis?
I think it's an infiltrative ductal carcinoma.
Okay. So we have 2 diagnoses here now. One is invasive lobular, and the other one is invasive infiltrating ductal, right? So we need a consensus from the class. Anybody else who is supporting these one? Go ahead. I just want to see a majority vote towards either lobular carcinoma or ductal carcinoma.
Ductal carcinoma.
2. So we have 2 votes for ductal carcinoma and 1 vote for lobular carcinoma. So we need some more votes. Go ahead. Yes. Yes. What do you think?
Ductal.
Ductal. Okay. So we have 3 votes for ductal and 1 vote for lobular. Is there anyone who is supporting lobular? Or everybody is supporting ductal now? Yes, come on.
I think it is lobular.
So we have 2 votes, or you are the same person?
No, I am different person.
We have 2 vote for lobular and 3 vote for ductal.
Yeah.
Okay. Now let's start with the. I'll coming up to the point. So now this is a ductal carcinoma. This is not a lobular one, right? You can see well-formed ducts present here. I'm just circling the ducts. See the duct. Lobular carcinoma, usually you see, probably you might have missed with this pattern, huh? Which
Yes,
is
Indian
called,
filing.
yeah, Indian filing. But in the Indian filing one, we don't see ductal structure, right? Like this one. That's why we have selected this case, because it was a little bit challenging one. But this is well-formed ducts, which you're looking at the lumen also. This is a lumen in between, in the duct. In Indian filing, you just see cells like this one without any ductal formation. So that is a peculiar finding of lobular carcinoma. But at least you are coming up to the point and you have given me the reasons that you are looking for an Indian filing. It's a very good thing that you are thinking in that direction. So now, after looking at the ducts and the lumen, although we have some of the ducts which are cells which are present as an Indian filing, but if you see it clearly, again, these Indian filing cells are also forming a ductal structure. So majority of the cells which you see, they are forming a ductal structure. So when you see such ductal structure, you call it ductal carcinoma. Okay, so it's not a lobular one, it's a ductal carcinoma. Coming to the questions. Question number 1, microscopic finding.
I think we just answered that, doctor.
So we have a lot of ductal structures, right? And again, we have cells which have large hyperchromatic pleomorphic nuclei, mitotic figures. And the other thing which you see here is a lot of fibrous tissue. This is called scarce structure or scarce carcinoma. When you see a lot of fibrosis around the duct, it becomes very hard. Okay. Question number 2.
Is the lesion malignant or benign?
Hmm.
It's malignant.
It's malignant because it's infiltrating into the stroma. So it is definitely a malignant one. Acha. Question number 3.
What chemotherapy is likely to be beneficial?
Okay. So,
I don't know about that, honestly.
okay, no problem. Anybody else who wants to try to answer this question?
Tamoxifen.
Yeah.
Tamoxifen. Okay. Why you are asking saying tamoxifen? Because?
Because the tumor is ER
Very
receptor
nice.
positive.
Yeah, very nice. Anything else you want to mention? Which
Yes,
thing
Herceptin, I guess it's called.
Herceptin, right?
No, Herceptin wouldn't work. No, it's negative. It's
Negative, because HER2 is negative. So you will not give Herceptin, you will just give tamoxifen in this patient. Okay, good, excellent. Question number 4.
Can there be metastasis despite non-palpable nodule?
Yes. So
Uh,
what will be your answer? Yes, go ahead. Go ahead. What is the size of the tumor?
so
What is the size of the tumor?
7 centimeters.
7. So what will be the prognosis? Okay, let me ask in a different way. The size is 7 centimeter, right? So what will be the prognosis? How will you grade the tumor? Hmm? Now, okay, let's discuss this thing. Anybody wants to jump in and say something so that then I'll start? Anybody has some idea about this palpable lymph node, whether she is having or not? Any other student? Yes,
Sir, isn't the tumor a bit too big?
too big. So what's the chances now?
It's a
It
pretty
is,
high chance.
yes, very high chances. Probably the axillary lymph nodes are not that much enlarged, but there is a chances that this patient might be having nodal metastasis. Now, the nodal metastasis, when it become big in size, then you can palpate. But if it is just a recently been metastasized, a size of the lymph node is small, you cannot even palpate, right? So there is a large amount of chances that this patient might have a nodal metastasis at the time because the size is very big, and the prognosis of the size of the patient depend upon the size of the tumor. For example, if it is 2 centimeter or less, the prognosis will be better. And if it is more than 2 centimeter, it is 7 centimeter. So the prognosis will be bad. Plus, you do a grading. In ductal or in a breast cancer, how will you grade the patient, the tumor? You see 3 things. One is tubular formation. How many how many ducts are being formed? So it's a tubule. So if you see here, as you see in this picture, the ducts are identified. For example, this one, and there are some areas in which you are actually thinking that it's just Indian filing. So if you would have seen only this type of pattern, then you could have graded at 3, means less amount of ducts. Hardly you can identify. It's 3. Now here in this histology, you can see the ducts as well as some cells are lying not forming the duct. So it is not one. In one, it is all duct formation. Easily you can see all the ducts. In 2, some of the ducts are formed, some of the cells are lying individually. And in 3, you can hardly see any of the duct. So number 1 is tubule formation. Number 2, morphology of the cells. How much pleomorphic the cells are. So it is not that much pleomorphic. I can grade it as 2, right? We divide everything in 3, 1, 2, 3, 1, 2, 3, 1, 2, 3. So I can give 2 marks to this one. And the last one is mitotic figure. So if it is 10 mitosis per high power field is 1. If from 10 to 20, it is 2. If it is 20 and more, it is 3. So this is how you grade. For example, although it's low power, for looking at the mitosis, you had to go for a high power. So actually this one mitosis, this is second mitosis, this is third mitosis. So you have mitosis here. So if I go in a high power, probably I will see in between 10 to 20. So I will give this one as a 2 marks. So for tubules, we give 2. For cellular morphology, we give 2. And for mitosis, we also give 2. So this is pleomorphism. So 2, 2, 2 is 6, right? So if you see, this 6 will come into the moderate type. So this is probably a moderate type of differentiation. Means it's not very mild type, it's not very high type, it's in between one, right? So if you give it 6 points, so it's not very high. Okay. Uh, Coming to the next one, case number 4. Who is going to read this one?
Can I take this one, sir?
Yes, please.
Okay, so a 46-year-old woman with left thyroid lobe enlargement and a large non-tender left anterior cervical lymph node has normal TSH and thyroxine levels. Microscopic appearance of her resected mass is shown. Her next CT scan is also shown. Which one of the following is the most likely diagnosis of this patient?
Okay,
It's papillary carcinoma B.
B. So everybody agrees that this is papillary carcinoma?
Yes.
Everybody agrees it is papillary carcinoma, right?
Yeah.
Okay. Anybody else who have a different diagnosis? No. Okay. Coming to the questions. Question number 1.
Describe 4 microscopic features of this lesion.
Okay. What's the microscopic for?
Yeah, so the first one that we can see clearly is the orphan
Okay.
NEI nuclei. We can
Very
see,
nice. Okay.
and then we can see the papilla with the fibrovascular stalk,
Yes. Very nice. Okay.
and we can also see the samoma body on the
Okay.
tip of the papilla.
Okay. 3. What is the fourth one?
Intranuclear grooving and intranuclear inclusions.
Very nice. So we can see the groove here easily. There are a few nuclei which can show you the grooves, but inclusion is little bit difficult to find. Probably this cell has an inclusion in it. Okay. So yes, so these are all good diagnostic points. Question number 2.
Yes, name the 2 gene mutations of this lesion.
Okay.
So the first one is the RET PTC gene
Mhm.
and the BRAF gene.
Okay. So if you see BRAF gene, then what will be the prognosis?
It's
Adverse prognosis makes
Yeah.
it worse.
If you see
Yeah,
only
it's
RET/PTC gene, then the prognosis is good. But if you see BRAF along with this one, then the prognosis is little bad. Question number 3.
what is the prognosis of this lesion? It's a good prognosis if
Good
it's
prognosis. Yes.
Yeah.
And the 10-year survival rate is almost
90%.
90%. Good.
90%.
Even if somebody had BRAF mutation, so normally we consider it as 95, but if you have BRAF, means probably 90 or plus minus. Even then, having BRAF, it doesn't show that 5-year survival rate comes down to 50%. No. Even have a BRAF, but as compared to the without BRAF one, the prognosis is good. Okay. Last one.
What is the risk factor for this disease?
Yes.
Past history of neck irradiation.
Very good. Ionizing radiation is the best one. So somebody was asking a question regarding the tumor.
Yeah, it's me, doctor.
Please go ahead. What's your question?
Doctor, for the classification of malignancy in the thyroid cancer, you said that we classify malignancy based on the vascular invasion and capsular invasion, right?
Not always. I have mentioned that
but
for
the question is that
follicular carcinoma, we have 2 major groups of tumor in thyroid. One is papillary carcinoma, and the other one is follicular carcinoma. So if we talk about papillary carcinoma, the differentiating point for malignancy is what you have mentioned now, that we should have orphan eye appearance of the ground glass appearance of the nuclei. We have a nuclear grooving. nuclear inclusion, right? We could have what you call SOMOMA bodies. So if we have our papillary structure, this is typical of papillary carcinoma. Don't mix this thing with the follicular one. For follicular carcinoma, you will not find any of these features for malignancy. For follicular carcinoma, you had to go for either capsular invasion or vascular invasion, right? For
Yes.
follicular carcinoma, yes.
Yeah. It's just I was confused because you explained it at the beginning of the lecture, so I said it's maybe all.
No, I already mentioned in my lecture also that for papillary carcinoma, we have these type of features. For follicular carcinoma, we had to see capsular and vascular invasion. This ground glass appearance, nuclear grooving, nuclear inclusion, SOMOMA body, they does not show in a follicular carcinoma. Please make it very clear that in follicular carcinoma, even the cells looks very normal. There are well-formed follicles in the surrounding. But if you don't see vascular invasion and capsular invasion, it's a adenoma. But if all blend-like structures, no pleomorphism, no hyperchromasia, but it is invading into the capsule, then it is malignant. So you call it as a follicular carcinoma. Because for follicular carcinoma, nuclear feature is not an important thing. You don't have to go for pleomorphism. You don't have to go for atypia, pleomorphism, hyperchromasia. No. You had to see a capsular and vascular invasion. Right? Is it
Yes,
clear
doctor.
now?
Yeah.
Is it clear now?
Yes.
Okay.
Thank you, doctor.
Welcome. Okay, let's go to case number 5 now. Who is going to read this one? Anyone
can do
from the
it,
girl
doctor.
side? Okay, you are going to start.
Yeah. Okay. A 13-year-old girl collapsed while playing basketball on arrival at the emergency department. She was partially unconscious. On physical examination, she was hypotensive and tachycardic with deep, rapid, and laboral respiration. Laboratory studies showed serum sodium 151 and potassium 4.6, chloride 98, bicarbonate 7, and glucose 521. Urine analysis showed +4 glycosuria and +4 ketonuria, but no protein and blood. Histopathology of the pancreas is shown. Which pathologic abnormality is most likely to be present in her pancreas?
Okay. So
Okay.
what is your answer?
Yeah, it's insulinitis.
Insulitis.
Insulitis, sorry. Right.
Okay. So why you call it insulitis? Why not anything else? So what is basically your diagnosis?
Yeah, it's type 1 diabetes.
Type 1 diabetes. And why are you calling it type 1 diabetes?
Because her presentation, she's young, that's first.
Yeah. 13 years, okay.
The acute presentation of the ketoacidosis.
Okay.
And the fact that okay, hypertensive, tachycardic, unconscious. Yeah, I guess that's it. Ketonuria.
While looking at the microscopic pictures.
You mean the microscopy?
Yeah.
Yeah. I see the inflammation of the islets of Langerhans.
Islets of Langerhans. You can see that this is preinsulitis, peri-insulitis, intra-insular insulitis, and then complete destruction of this. So here you can see complete destruction. So there is no beta cell left, right?
Yes.
So this is the reason why you are thinking of calling it as type 1 diabetes. What happened in type 2 diabetes? If you see microscopic picture.
Amyloid.
Amyloid. Very nice. Excellent. So this is the most important differentiating point. In type 2 diabetes, you see amyloid, but you will not see a single lymphocyte in type 2 diabetes because the pathogenesis of type 2 is totally different. So what are the two important things type 2 diabetes? Number one is
amyloid and no inflammatory cells.
No inflammatory cells. And if you talk about the pathogenesis, what is the most important two things in type 2 diabetes?
It's the insulin resistance and
Very
the
nice.
dysfunction of the beta cells.
Very nice. Excellent. Very nice. What's your name?
Brahim.
Mashallah. Mashallah. Okay, go towards the questions.
Okay. Enlist 3 laboratory criteria to establish the diagnosis of diabetes mellitus. Okay.
Can you tell us
So,
3 criteria? Number
yeah.
1.
Fasting blood glucose more than 126
Very nice.
with the clinical presentation of the 3 Ps: polyuria, polydipsia, polyphagia.
Number 2.
It's oral glucose tolerance test showing more than 200.
Oh, okay. Number 3.
Yeah, and random glucose more than 200 with the clinical features also.
Very nice. Good. So this is the important thing which you have to note. Coming to question number 2.
Yeah. Name 2 genes which are most likely to show polymorphism in this patient. Yeah.
So it is
CTLA4 and PTPN22.
Very nice. So can I ask where you see polymorphism of these genes in what other structures?
What other structure?
Yeah.
You mean disease, doctor?
Yeah. Apart from diabetes, any other disease which can have these 2 polymorphisms?
Yes. I forgot. So,
Was
No,
it
I'm not
Hashimoto?
talking. Yes, go ahead.
Was it Hashimoto?
Yes,
Hashimoto's,
Hashimoto.
yeah.
And the other one is
Graves.
Graves' disease. So you can have a same type of polymorphism in these 2 diseases. Okay, remember. So we have basically only 3. We are just talking about our endocrine. We are not going anywhere else, right? So there are 3 diseases in which we have polymorphism of these 2 genes, and one is type 1 diabetes. Number 2 is Graves' disease, and number 3 is Hashimoto thyroiditis. Okay, coming to question number 3.
Okay. By looking at her labs, which complication has developed in this patient?
What's your answer?
Ketoacidosis.
Ketoacidosis. So can you tell me how the ketoacidosis is formed? It's just a general discussion. Yes.
Yeah. Okay. Well, the body can't utilize glucose.
Yes.
So it will look for an alternative source for energy.
Very nice.
It will start breaking down lipid tissue and releasing free fatty acids.
Very good.
That will mobilize to the liver and become esterified. Or become oxidized to acetyl-CoA. And then it will form ketone bodies.
Okay, ketoacidosis. Okay, ketone bodies. So what will happen then? What will happen after forming these ketone bodies? Or yes, go ahead.
Yeah. What do you mean, like ketonuria and?
Yeah. So what will happen?
If there is the urination basically, or there is dehydration, the level will increase and it will affect the brain. I don't know what's the level exactly.
Very nice. So if the patient is in a good condition, and if he is or she is taking ample amount of water and dehydration is okay, then the body will try to get rid of these ketone bodies as a ketone urea, right? So ketone urea will be, and a ketone body will be excreted from the urine. But because as the ketone body slightly increases, it will cause a dumbness of the brain. So patients usually, if you see, these patients are usually very, very weak, and they lie on bed and they does not take excess amount of water. So if there is a dehydration occurs, this ketone body start accumulating in the blood, and it goes to the brain and cause ketoacidosis and coma. Okay. Coming to question number 3. Question number 4. Sorry.
Okay. Unless 3 microvascular complications most likely to develop in this patient in the future.
Okay. So.
Okay. You got neuropathy, nephropathy, and retinopathy.
Very nice. So this is why we have given this picture. This is basically retinopathy, and this one is a nephropathy. And neuropathy, the peripheral nerves get involved. Okay, so this was
Yes.
all regarding case number 5. Anybody who has a question in this case, or should we move? Okay, let's move to question number 6. Who's going to read this one?
Can I read it?
Yes, go ahead.
We have a 28-year-old woman presented to the gynecologist with absence of menstrual periods for the past 4 months.
Mhm.
Though her pregnancy test was negative at 2 occasions, and she had no physical signs of pregnancy. Within the past 2 weeks, she has noted some milk production from her breasts. She is also having a headache for the past 2 months and also complains of some visual disturbance.
Okay.
On physical examination, she is afebrile and normotensive. MRI of the brain shows a 0.8 centimeter mass in the adenohypophysis.
Hmm.
Histopathology of the adenohypophysis is also shown. Which of the following additional complications is most likely to present in this patient?
Okay.
The
Hmm.
options are hypertension,
Hmm.
diabetes mellitus, loss of libido, and non-pitting edema, and Sayad
Hmm.
syndrome. I think it's C, loss of libido.
Yes, loss of libido, because the other features are not related to this one.
Mhm.
The most important one is a loss of libido. Okay. Everybody agrees with the answer, or somebody has some other one?
Yes, it's correct.
Okay. Coming to the questions, go ahead. First question.
First question is, what is the mechanism of amenorrhea in this case?
Mm-hmm.
So this lady is having a prolactinoma,
Mm-hmm.
which is producing excess prolactin, and
Mm.
prolactin is known to suppress the GnRH, which is
Mhm.
responsible in to produce FSH and LH. So
Mm.
without those, she'll have anovulation.
Okay, very nice. Question number 2.
And list 4 factors leading to hyperprolactinemia besides prolactinoma.
Mm.
So hypothyroidism sometimes
Mm.
can cause prolactinoma.
Okay.
Renal diseases,
Mm-hmm.
not excreting it.
Mm.
If the patient is taking any anti-dopamine drugs.
Okay, good. Yes. Then number 3.
Sometimes stress can
Stress
cause
can
that.
also cause. Anything else?
I'm
Yes.
not
Any
sure.
other student? Any other student? You can jump in.
Pain,
Sorry?
pain.
Pain.
Yeah.
Yeah, that is included in the stress, right? Because when you have pain, you have ample amount of stress. So that will cover that. Okay. Anything else? In pregnancy, you can have these features. And plus, if a baby is, a fetus, sorry, a baby, a small baby is doing nipple suckling, that will also cause increase in this one. Okay. So these are the few points which is important. Okay. What is the, come to the other question?
What will be the most likely clinical presentation of this tumor in males?
Hmm.
Uh,
Now,
so the
mhm.
so basically erectile dysfunction and loss of
Okay.
libido as well. We
Mhm.
might see gynecomastia.
Very nice. Very nice. Good. Anybody else? Anybody who wants to say something regarding this one? No. Okay. Uh, what is the mechanism of visual disturbances?
Mass effect, compressing
Mass
on the
effect.
yeah.
Now, even you can see here, for example, okay. So you can see here, this is whole tumor which is increased in size. Probably it is compressing the optic chiasma, which is passing through that, right? Around this one. So it's a mass effect which can cause visual disturbance. Okay. Any question regarding this one? No? Okay, so we have completed the CPC. What I will do is I will upload the correct answer sheet in a Moodle for you people, especially for you people. I never do it before, right? I'm doing it now because to help you out for this exam. Inshallah, the examination will be good for you. It is almost complete, and you will have any question regarding exams you want to ask.
Yeah, doctor, I have a question.
Yeah, sure. Go ahead.
Regarding the grading for the tumor, are we expected to grade, like to give an accurate grade, or just giving the criteria?
You're talking about which tumor? Which tumor of breast? If you talk about the breast one, then if you for example for grading the breast tumor is absolutely different, because you have to see the tubules, we have to see the cellular morphology, and number 3 is mitotic figures, and then you total all of them and then you grade it. But if you're talking about other tumor like uh, ovarian tumor, for example, so you can grade it low grade and high grade. Basically, majority of the tumors we have just confined to low grade and high grade. Right? Rather putting in it mild, moderate, and severe, we have just kept in a 2-1. Just hold on for a second. मैं जरा क्लास में हूँ, सर मैं ये पूछ रहा था आप कितने बजे तक वापस जाएंगे? आप कितने बजे तक जाएंगे वापस घर? मुझसे पूछ लीजिएगा, प्रॉब्लम मैं आपके साथ जाऊँ, आज मैं गाड़ी में नहीं आया. ओके, थैंक यू. Sorry. So for the other tumors, you can differentiate into low grade and high grade. For breast, we have to go for mild, moderate, and severe, right? Any other question? Hello. So we are done. Anything regarding the exam?
Thank you, doctor.
Okay,
No,
thank you very
thank you,
much.
doctor.
Thank you. I'm just, after this, I will be uploading the correct answer sheets. Okay, thank you very much. Best of luck for your exams.
Thank you.
Welcome.